So moving on to our third patient. So she was a 36-year-old lady. She was a known case of SLE. So systemic lupus erythematosus. This is kind of an autoimmune disease. She's been having it for around 8 years. And for 8 years, she had other organ involvement. Only for the last 2 years, she found out that it affected her kidney. At the time of diagnosis, her creatinine was 1.9. Because it was a autoimmune disease, she was started on some immunosuppression. Again, the problem with most of our patients is they have a lot of issues with taking medicines. So we have around 6, 7 medicines, sometimes even 8 medicines, and people are like, why am I taking so many medicines for so many years? I want an alternative solution. And then they ask people at home, they ask people, they ask their relatives, and then their relatives have this one wonderful miracle story that, no, no, you don't go here, you go to one particular magic doctor who will give one medicine and everything will go. And then they believe that, and then they end up, uh, just one miracle option is one. It's understandable from the patient's point of view. They just want freedom from all of these medicines. So they even start feeling better taking those medicines. So they continue on that. But then sometimes things get bad and they end up coming back to us. So this is a common circle that many doctors and nephrologists will tell you that, there is a patient of theirs who started, we only diagnosed, we only gave them initial treatment. They were on good follow-up. Suddenly they lost follow-up, went in for native medications, and then they come back to us with complications. So this girl came back with history of multiple fractures following trivial trauma. Another thing that is not understood about kidney disease, and many people don't understand, is that kidney indirectly has a major role in your bone health and your blood health. We see a lot of anemia, we see a lot of what we call mineral bone disease when there is kidney failure, which is why you have patients who are taking this erythropoietin injections and iron injections a lot on dialysis. Because the kidney plays an important role in producing a hormone called erythropoietin, which is required for blood to be produced. When there is kidney failure, you will have anemia, and that needs to be treated with these iron injections. So, and another thing is bone health. So, bone health, blood health, all of these are indirectly affected because of kidney, and which is why I always, though I'm a nephrologist, I'm biased on this. I always promote is the kidney is like the master organ. Everybody has this fascination with the heart somehow. I mean, I personally, to be very honest, until I was doing my 12th standard, I want to be a cardiologist because it looked fascinating. The first thing that we hear about when we see health as a symbol, you will see heart. And when you go to your undergraduate and you buy your first stethoscope, you're very excited to hear that lumped up sound. And it's always cardiology. Heart is where the all the fascination comes. I was even telling somebody the other end. No, we even it's gone to the extent that even if you propose to somebody or you say love, it becomes you talk about the heart and as the greatest organ. So it has always been a fascination for the heart, but to me it's always the kidney, which is a wonderful organ, which is like the silent guardian, which is like the real dark knight and the watchful protector of our body, which doesn't make any noise. It keeps going on in the background and does a lot of the work, and which is why it's so wonderful. Anyway, I'm debating here, but yeah.
Yeah,
So
one point, Doctor, actually, you were
yes.
narrating one point is that so some patient actually so tend to follow the advice from the relatives. Sometimes the placebo effect also come into play, and they believe some of the medicine, and to some degree, to small degree, it helps. But actually, by the time indirectly the kidney health is getting worsened, right? So I think that is also you might, of course, you might must have seen a lot of cases on this also as well. So can you
True,
just
sir.
slightly put some light on placebo effect, Doctor, so that our
True, sir.
viewers can understand how it makes a difference. Yeah.
Sure, true. So this is something that is very true of late. Even in the era of information, like even people like you are doing such good work in trying to get out good information to the public. Because of this same avenues, a lot of misinformation spreads a lot more easier, and it's almost sensational when you say, "I have a medicine to bring down creatinine," and if on the other hand, if I say, "I'm sorry, I don't have anything to bring down creatinine." A lot of sensation will be there if I release a 30-second video saying that I have a magic pill to reduce creatinine. And see, this is again a topic of controversy. I don't know how much I can explore into it. But alternative medicines, this can be either your Siddha or homeopathy or Ayurveda, has a brilliant history, has a fascinating story as to how each of these fields of medicine have evolved. And if you read into literature, homeopathy or Ayurveda or Siddha was meant to be a natural form, a naturopathy in a way, wherein natural ingredients were adopted and diluted and a way contributing to overall health. This is the origin story of many of these sciences. But what has happened over the years is there's been a not a stringent regulation on many of these products, many of these items. You don't. There is no regulatory authority which is focused on this, which says that you should not use more than this amount of this element or more than this amount of this metal, and you don't understand what is actually inside. You have powders, you have small tablets, you have black colored balls, you have white colored powders, and you don't know what is actually content in that. You don't know. For example, if I want to start a new company, and if I want to produce even a simple drug like paracetamol, I have to go through multiple regulatory authorities, make sure that that tablet should contain only paracetamol, only 500 milligram, and only then I can probably think about introducing it into the market. But when it is a lot of the alternative medicines, the regulatory authority isn't as strict as what I would personally feel. And in addition, there aren't many trials which establish benefit. What we have seen is there is some content of a low dose of maybe a steroid, maybe an NSAID, maybe some degree of alcohol, maybe some what we're seeing commonly now is heavy metals. There are a lot of heavy metal toxicity which is adding on. We've even done analysis and found out that levels of mercury, lead, cadmium, and all of are higher in many of this. So I wouldn't blame the entire science. I wouldn't blame the entire field as such without knowing their entire history. But I feel that it is lost regulation, and that many times many of these compounds are present in thousands and 10,000s more than what they should, and which is why sometimes you have a feeling of well-being. You eat better, you put on some weight. Maybe it's the effect of steroid, maybe it's the effect of some element inside, but in the long run, this actually doesn't translate into good outcomes, and then we end up seeing a lot of the complications, and then by that time it's too late. And it's quite unfortunate because you're kind of exploiting somebody's insecurities or exploiting somebody's uh, state of mind. They're looking, searching for a solution, and you're offering something without evidence. I feel is it's not right. So, and this is something that people should be very, very aware of, should be very clear about. And today we have. It's not like you don't have ways to understand what is true and what is false. We have internet, and AI has actually improved so many things. And I can these days even I feel very comfortable telling my patients, if you don't trust what I'm saying, or if you don't believe what I'm saying, put it on ChatGPT and tell me what it does. So it's a neutral way to, even talk to your patient. There's no more hiding. The information is all out there. And if patients are ready to take that in, and patients are ready to really analyze what they want to take in as a tablet, I think that would make tremendous change to our field and kidney health overall. Because what happens is it's and the alarming and the sad part of this is these medicines are not cheap in any way. They're in fact expensive,
True,
but then
true.
somehow there is a belief and there is a trust that something that is marketed as natural is never harmful, and that word natural is what ends up convincing them. And supported by that is one story in the family of somebody taking one tablet and their problems disappearing. And that becomes, so what I tell them is mostly it would have been a stone, it would have been an infection in the kidney, and they would have had water and they would have passed out, the creatinine would have come down because of that. But they will say that it is because of that magic pill, it will because of some mukar taking, and it is because of all of that. So what I tell my patients is take all the fruits, vegetables, whatever is natural you can take, but any powders, any tablets and all that, without knowing what is inside, please don't consume. And that we would be the first people to put it out to the world if it's actually causing any benefit.
True, true. Well said, doctor. Yeah, please go on, doctor. Yeah, well
Yeah.
said.
So this was the latest. She came back with multiple fractures following her trivial trauma. So over a period of time, her symptoms worsened. Her urine output dropped to less than 100 ml per day, and she was started on hemodialysis. So when patient is on dialysis, the other option that you have, apart from hemodialysis, apart from peritoneal dialysis, and often there's another thing I want to talk about. This is something called as home dialysis. So these days you can do dialysis at home as well. There are ways to maintain the machine at home. The only thing is the water that you use has to be running through your blood and coming out. So because that the cleanest form of water is what is important. So maintaining that purity, maintaining that cleanliness putting a needle into that fistula. All those are difficult, which is why home dialysis has not yet picked up to a greater extent than probably in the Western world, but it is significantly improved, and that is another option that is there. So home HD as a whole, hemodiafiltration, then there is this peritoneal dialysis. And all these options are a better form of renal replacement therapy or a way to improve the kidney's function. The best part is renal transplant, and which is why, so for her, she had her father who was a prospective renal donor. And then, so we had a complete evaluation for her father. So the most ideal renal replacement therapy is your renal transplantation. And to kind of give you an idea as to what are the transplants and how transplant happens, we should understand that there are two types of kidney transplant. One is a life related renal transplant, meaning that somebody in the family who is related gives a kidney to the patient with kidney disease. So this is a live transplant related from the mother or the father or the spouse or the brother or sister or grandfather, grandma, somebody in the family gives their kidney to this patient, and that is your live related renal transplant. The other option is a deceased donor renal transplant. We'll talk about this in a while. So this is another misconception that is commonly thing, and to be very honest, I didn't know it till I was in say MD general medicine. So this is our normal kidneys. Normal kidneys produce your urine, and it comes to the blood and passes out urine. I thought these kidneys will be removed and transplant will happen, but the
Even
actual
I do
truth
thought the
is,
same, doctor. I do thought the
so
same
even
because
I didn't know, even till MD, I didn't know this, sir.
yeah.
So we don't even touch any of this. We keep an extra kidney here, and then we attach the ureter to the bladder. So this is another thing that many people don't know. Many of us also don't know. Many of us, I'm sure, even other fields in medicine also will not know that the third it's kept as a third kidney. And the reason why this is done is even with the kidney is in place, around 5% of kidneys will continue to function. It's even on dialysis, around 5%, around 100 ml of urine. Some people have even more amount of urine being produced. And we want to try and bring out as much function of the kidney as possible, which is why we don't meddle with any of this. We are okay with the kidneys being there. There are only rare conditions when we take out the kidney, wherein there is some infection which is not settling, where the kidney sometimes due to certain conditions are very enlarged. So you have a large kidney, you don't have place, and there are specific indications. I don't want to go into the details, but in such conditions, you would remove the kidney, but otherwise, it is always a third kidney that is transplanted. So this is another misconception, something is very interesting to note. And to slightly talk about the history of your transplant. So first thing, the luckily the first transplant happened between identical twins. So that immunology, that rejection, all of those concepts never happened. And from there on, now we have around 50 years, 70 years later, now we are into this entire new world of transplant where we have a lot of drugs which prevent rejection and we are worried about rejection. We'll talk about rejection a little later. But so this is your transplant, how it happens. So if somebody is on dialysis and say her father wants to give the kidney, we have a lot of battery of tests that we do. We kind of run through these tests for both the donor and the recipient. If they're completely fit and we get all sanctions from the hospital as well as the government, we go ahead, we remove the kidney from this patient and we place it as the third kidney to the recipient. And once that happens, and what's fascinating to note is that somebody who was producing less than 100 ml of urine per day will end up producing 1 liter of urine per hour. And that is how, that is what, is every nephrologist's dream, is what we say, looking at that euro bag and seeing so much of urine coming out. So the other thing is this kidney doesn't have brain regulation. It's kind of a denervated kidney wherein you will not have complete regulation. They will not know. They just basically throw out all urine that comes to the kidney. So we end up marking urine output of 22 liters per day, 18 liters per day. As the urine keeps coming out, we keep putting in more fluid, more urine output, more fluid. And somebody who is not producing urine in one day will end up producing almost 800 ml to 1 liter per hour. So this is what a wonderful mode of replacement therapy it is. It's almost like on table you're curing somebody's kidney failure, which is why it's wonderful to have this idea of renal transplant in. And for us, the priority is always the donor because though they are family, somebody who's absolutely fit, absolutely healthy, are coming forward and doing this altruistic act. So as a nephrologist, we always say taking care of recipient is important, but taking care of the donor is very, very important. Somebody should be. So there are people who come to us anxiously and ask, sir, I'm donating my kidney. Is there some harm that I could face in future? There have been various studies and various follow-up has been done through the years, and we have seen that yes, definitely there is an impact when you have only one kidney, but that your lifespan is equivalent to somebody who has both kidneys. And the only thing is that you should monitor your comorbidities like your BP, your sugars, your lipid profile, your obesity. If there is any protein leak, it is just like you're driving a car with lesser air in your wheels. You just have to be extra cautious and make sure that you're doing the necessary top up, you're on periodic follow up. That it's we as a protocol, we always make sure that the donor is doing well. At every follow up, we keep asking about the donor and making sure they're doing well. So this is about the live related renal transplant. The other option is, so not everybody, and this is again something that we're seeing commonly in our population now. Now we've almost switched over to a single child, no sibling family. So I feel 10, 20 years from now, we may not have as many donors as we used to 10, 20 years back. And it's very rare to see a 60-year-old or a 50-year-old mother or a father, somebody having no BP, no sugar, or no comorbidities. And so the donors pool is going to be a lot lesser in the coming years. This is something that the Western population are already having. So they don't have live transplants as much as we do in India. The other thing that the option that they have is this diseased donor renal transplant. So if there is nobody in the family to give a kidney, the other thing that we do is they have to register in the statewide registry. So this is a huge waiting list. So it's around the average waiting time is around 4 to 5 years currently in our state. It's probably improving because there was a major lag because we couldn't do transplants during COVID, and there was a huge pandemic, and giving immunosuppressant drugs were not at all an option. So transplant had stopped for around 1 or 2 years, and which is why the waiting list is longer. We expect that the waiting list should somewhere shorten between 3 to 4 years in some period of time. But there is a blood group based waiting list. So if you are starting on dialysis now, 1 to 2 months post the start of your dialysis, you can register on the state transplant registry. And based on your seniority for each blood group, when there is somebody, say there is an individual who has undergone, there is a car crash or some road traffic accident, they're on ventilator and they have been pronounced as brain dead, the family of this brain dead patient can say, I am willing to donate my husband's or my son's, my brother's organs to the community. In that way, after getting an informed consent and after the necessary formalities, each of these organs, based on which consent has been obtained, is retrieved from this donor, and that is rushed to the hospital. And for example, the heart, the lung, the liver, the kidneys, and based on this priority listing, this renal transplantation happens. And this is like a way for the patient who has come forward to know. So one patient who had an unfortunate event has given life to around 7 8 other people who are having an organ failure. So this is again another reason why we promote a lot of us to go ahead and do our organ donation, because sometimes things aren't in your hands. Sometimes you can't predict what could possibly happen. And when this event happens and you're already in a lot of turmoil and already in a lot of distress for you as well as the family, and for a family to come forward and take this decision is a great deal. But if that decision is made, it's wonderful that you although you are going through some untreatable condition, your organs are still working well. And if you take in the organ count from your eyes to your kidneys, 7 8 individuals are independently improving and back to their normal life because of this act. This makes it again, which is why again even the state transplant organization, we have like a parade for the donor when any time this retrieval happens in the state hospitals. So again, this is another thing that has picked up a lot of late, especially over the last 3 to 4 years in our state in Tamil Nadu and all over India. This has picked up a lot. And this is the other option. Somebody does not have a donor. This disease donor renal transplant is the other way to liberate somebody from your hemodialysis. And once transplant is done, is that the end of the story? So what I would generally tell my patients is like transplant is like marriage. It's like getting married. All the halabala and all the gala event, all the preparation, all that will happen to that date, but then the journey starts after that. Yes, getting that done is important. Getting the timing right is important, but the real picture starts after the renal transplant. And what is important to understand when we talk about renal transplant is you're keeping somebody else's kidney in your body. So it can be your mother, it can be your father, it can be your brother. It's still a foreign object for the body. So the body has a tendency to fight against that particular organ. The body says, "What is this? Something new? Let me send out my antibodies and fight with that." But that should not happen. And when that happens, we have this unfortunate complication called as rejection. So to avoid this, we give a lot of immunosuppression, which is like drugs given to suppress immunity. There are some injection drugs which are given during the time of transplant, which is to rapidly suppress your immunity. And there are long-term drugs. So another thing that people don't understand is transplant. After transplant, you should not be missing even one tablet, even one time a day. You should keep your body constantly suppressed of your immunity. And there are obviously, I mean, the next question immediately would come from my patients: are there any side effects for these drugs? Any drug would have its side effects, but it's more of valuing your risks versus your benefit. And at this period of time, if by skipping a tablet you end up having a rejection and the kidney is lost, imagine that all these steps are going completely to waste. So, which is why it's very, very, very important that people maintain stringent surveillance. People come for periodic follow-up and people take their tablets on time. So the other question would be, if this is the case, why don't I overload myself on immunosuppressions? I don't want rejection. Why don't I just take a lot of steroids, take a lot of tacrolimus and other drugs? The other extent is you could end up having a lot of infections. So you would suppress your immunity too much, and then it goes into infections and the rare possibility of cancers in the long run. So this post-transplant tightrope, when you balance infection and rejection, is what the journey of a post-transplant patient is. So which is why taking pills on time, taking the necessary tests and periodic follow-up is very, very important. And patient should never think that, transplant is the be all end all, and that with that day the thing is over. It's like a marathon race where you continue to accept the kidney and continue to go about your routine work as well. So why I would wanted to point out these three stories was these three stories all started with a creatinine of 1.9 in one period of time. So this is the problem happens is sometimes we get a lot of these teleconsultations or we get sudden calls saying, "Sir, my uncle is in so and so place. His creatinine is 1.9. Tell me what medicine to take." It's not that easy at all. There are so many reasons why a creatinine for a patient could be 1.9, and there are so many ways in which this creatinine of 1.9 could progress. So to give you a summary, the initial patient present at 51 years, high BP, high sugars. At 58 years, he went in for dialysis. He wanted CAPD, so he was in CAPD. He didn't have anybody in the family for transplant, so he's on the DDRT waiting list as of now. This lady went in for native medications, some bone fractures. At 39 years of age, she went in for dialysis. Luckily, she had a father as a donor, and now she's following up with good graft function. The first patient who we saw who came back from the Gulf, he's been on OPD follow-up for a long period of time. And last creatinine is 5.3. So he has progressed to end-stage renal disease. So in these patients, what we do is we tell them you do a fistula now itself so that you can get an access ready. It doesn't mean that if you do a fistula, you have to do dialysis. It is just that it is a kind of an insurance. It's kind of how you pay your health insurance. Doing a fistula is like that. You have an access ready. If there comes a point when you have symptoms, when you have a high potassium level, when you have low urine output, when you're very breathless and you want to initiate dialysis, it's a very simple way to start dialysis than putting a tube. So this is what we say a fistula first initiative. So patients who have an EGFR of less than 15, we start doing these fistulas in a preemptive way. If they have a transplant option, transplant is better. If they don't have a transplant option, we try to get them ready for dialysis. And the reason why I presented all these three was to tell you that, the same value of a creatinine of 1.9 is not the same for each individual, and each person goes through various complications, and most of our treatments are tailored to what goes best for that particular patient and that particular scenario and that particular patient's family support and what form of dialysis would be helpful to them, whether transplant will be helpful to them, what form of transplant will be ideal. So it's very, very specific to a particular patient, and it's never as broad as, creatinine is 1.9, what drug can I take? It's never as simple as that. And which is why I would say, periodic follow-up and periodic visiting to the nephrologist and to your physicians. And what we promote now is primordial prevention, meaning that avoid it before it happens. So try and identify a high risk population, find out, especially with our changing lifestyles, it's becoming a major issue that, our processed food intake has increased. Now we say that, sitting is the new smoking. We don't move around a lot. Even we, as in doctors, are as guilty as patients. We sit in a desk and we entire day goes on that. So there are so much of our lifestyle which has changed and not in a healthy way. So identifying this high risk population, trying and detecting what is their comorbidities, getting their BPs under check, sugars under check, doing master health checkups. Again, people, there is always a contrary talk when people say it is a scam. People always have a negative view to healthcare. But what I would say is, we spend so much on so many things today. It's become we are no longer a saving economy. We become more of a spending economy, and we spend so much for so many things. And if we can't, I think it's very wrong if we can't take that effort to do a master health checkup to identify many of the things which are asymptomatic, like a kidney disease, and get our values clear, be aware about our numbers. That's very, very important. So, diet and lifestyle changes and restricting use of over-the-counter medications. This, I think, has reduced of late. I hope it has, because there's many times you see patients going to the pharmacy and just asking, "I have cold, I have cough, I have knee pain, give me the tablet." And so this is probably reduced because of some awareness. But again, as I spoke about, the indigenous medicines have again been a problem of late for us. And early treatment of acute kidney injury and following of those that survive from that acute kidney injury are all important. And if I want to tell you like 5 healthy habits, one is staying hydrated. So this is a very, very simple and easy tool that we don't do. Around 2.5 liters, 2 to 2.5 liters of water per day helps to avoid a lot of your dehydration, helps to avoid your risk of urinary tract infections, your risk of kidney stones. And this is very, very important. Second is you're getting a BP and sugar under control. Third is eating healthy, meaning lesser salt on the table. Say no salt on the table. Try and reduce the amount of salt that you cook, and don't keep it on the table so that you don't have the habit of adding salt while eating. Avoiding your use of any painkillers or over-the-counter medications, and as I said, get your blood values checked. And this was a nice initiative that we had at Curie Hospital last year when we said know your kidney numbers. Because many of our disease, as I mentioned, is very silent. You don't have these symptoms till the end. So if you want to know, we always are worried about the heart, worried about weight, worried about your BP, because you know those numbers. So if you want to know your kidney numbers, just three things. Make sure your BP is under 120. So systolic blood pressure, which is the higher side of your BP, should be less than 120. Creatinine should be less than 1.2, and the protein leak in the urine. So this awareness about this protein leak isn't there. So kidney is like a kind of a filter, like a tea filter or a coffee filter. The small pores wherein water starts to get filtered and gets produced at urine. But with age and with BP or sugar, those pores start to open up and have some inflammation. The spores get damaged. So beyond the water, heavier molecules such as protein start leaking, which is what presents as frothy urine or bubbles in the urine. People don't realize the symptom. People neglect a urine albumin or urine protein of trace or 1 plus in the urine. Even they say only 1 plus, what is it? What is that going to do? It's only trace albumin. What is that going to do? But it's very, very important that that urine protein is zero, because that is an early marker of your kidney injury. So when this BP goes up, this could be a marker of kidney injury or could be an effect of kidney injury. When the protein starts leaking in the urine, that in the long run ends up causing an increasing in the creatinine. So if you want to make sure today that, okay, sir, I am aware of kidney health today. I want to know if my kidney is doing well. What should I do? You don't need any magic test. Check your BP. check your creatinine, check your urine routine for protein leak, and maybe do an ultrasound alone. And if that is good, you needn't be worried at all. You can go about your routine activities. So this is just one final thought on acute kidney injury, and it was a very interesting patient who presented to us. He was a 26-year-old guy who we went to the gym, and they had some bet between them on how many sit-ups or push-ups you could do, and he ended up doing some 285 at one point of time. He came to us with high colored urine and decreased urine output to the extent of drop to less than 5 ml per day. He was a young boy, no comorbidities, absolutely good health, no smoking, no alcohol, no high risk behaviors. From creatinine of zero point 0.7, by just this single injury, the kidney shut down to the level of 7 milligrams per deciliter. His creatinine went up to 7. We started him on hemodialysis. He required 4 to 5 sessions of dialysis. And luckily, the kidney started to regenerate function. And this is what is the condition called as rhabdomyolysis, meaning the muscle breaks down and causes a kidney injury. So this is a success story of hemodialysis. So his creatinine came down to zero point 0.8. It has been almost 8 months now. We generally follow them up strictly for initial period of time. Now he's free from dialysis and he's very cautious about kidney health and he educates his friends. And what started as a bet, what started as a game, ended up to be such a dramatic change. His father came from Uttar Pradesh and he was somebody working in the army and. He was very surprised, shocked at this, and they were all very disturbed in the initial period of dialysis. But then he recovered. Not the dialysis did not cure the kidney issue. Dialysis supported the kidney's function. The kidney recovered with hydration, with the necessary treatment that was provided to him, and within 10 to 12 days, the kidney function recovered, and now he is doing very very well, and he's on 6 months follow up. So this is a different set of patients. So this is acute kidney injury, and this commonly happens when somebody is dehydrated, somebody has urinary tract issues, somebody has kidney stones, somebody has taken painkillers, somebody has worked out like this, somebody has had trauma. So this is a recoverable form of kidney injury. The other part, when this is not treated correctly, goes in for long-term chronic kidney disease. And sometimes not every AK recovers. This is another. So we've had an unfortunate event as well. Somebody had a snake bite. Snake bite caused a kidney injury, and due to a rare pathology, this did not recover. And that young boy ended up to having requirement for dialysis. And so what started as an AK doesn't always recover. So sometimes it ends up to be a chronic kidney disease. He required dialysis, and then his mother luckily came forward and was there to do the donor, and she donated her kidney, and currently touchwood the boy is doing well. This was another unfortunate story, but then again had a happy ending, and which is, I think, the message that we really keep promoting to all our patients. All our patients would always have some degree of a sorry story or an unfortunate event, but our role in most of these patients would be to always give them hope. You have an unfortunate event, you have a kidney shutdown, we have a hope of dialysis. You don't prefer hemodialysis, we have an option of a peritoneal dialysis. We have an option of a home dialysis. You don't want dialysis, you have a donor, we are ready, and there is an option of a renal transplant. If there is no donor, be comfortable on dialysis, and when it comes to your waiting list time, you will have another option as a transplant. So giving that hope and always giving that solution to our patient is where the actual world of nephrology lies. It ends up to be more of a therapy session more than anything else for most of our patients. And even for this patient, to be very honest, he kept asking me, sir, sixth day, seventh day, still my kidney is not functioning. What do we do? What do we do? To be very honest, even I wasn't aware if this kidney is going to recover or not. Yes, we expect it to recover, but we have seen patients who don't recover. So we also reassure him and we also reassure ourselves that we just keep doing the right thing and hopefully it recovers. And luckily for him, he ended up coming out of dialysis and he's leading a perfectly normal life today. So just want to conclude by saying, your kidneys take very, very good care of you by working 24/7, 365. We should really be appreciative about your kidneys. And, it's wonderful because no other organ in the body, we have two off and internal organ, and we have two off and we just need only one for normal function. Which I would tell, whichever God or science or whatever you believe in, it's fascinating that, they were so impressed by their own creation that they just decided, no, I want to just keep two in the human body. And somehow that idea has helped us to talk about donation and talk about kidney transplant. And it's wonderful what the kidneys do, and we should start taking very good care of them. And just the couple of images here. One is the Department of Nephrology in Madras Medical College, which inspired me, and is continuing to be the one person the person that I am, or the things that I've learned is fully from there. And today, as part of CURI and the department there, and Muthu Jayaram ma'am and Ajay sir. So the hospital has given me, has also helped me learn and helped me uh, make that 1% change to patients that I see today. So yeah, this is
Wonderful, wonderful, doctor, wonderful. And you have covered so many aspect and of dialysis, and then you have very nicely you build up the story, and then you went into transplant everything, and then transplant also is not a end of the journey, right? Again, post transplant also there are many things to be taken care, and all that you have very wonderfully covered, doctor. So I'm sure that all our viewers will take these lessons and take the kidney health and oral health for very, very importantly. They will take care of them. And I really wanted to thank you. I really
thank you.
like the number of 120, 120 bar 1.2.0 actually. So thanks to Kiri also as well. And for coming up and giving this very easy layman. I'm not a doctor, I'm just an engineer, but I can relate that number very easily and all that. So kudos to the entire team who is working on this journey, very, very difficult journey. And I can sense it that by just merely listening it, I can sense that so even doctor goes through a lot of calculations in the mind, everything and all that. So thank you so